Thanks and good afternoon. I'm really thrilled to be continuing the conversation from where Haiti left off on behavioral factors. So I just wanted to say a little bit about TasP and behavioral factors, and there have been a couple of commentaries recently that talked about who and what should be the target of behavioral interventions, and talked about how behavioral change interventions should focus on uptake of art, of course, most importantly, but also retention and care among people in sub-Saharan Africa. And what's been found is uptake and getting off of treatment is really the important thing to focus on with behavioral change, not as much adherence. Of course, adherence is important, but that seems to be less of the problem than just going off treatment completely. And also, commentaries have talked about behavioral change as especially critical among HIV-positive persons who engage in risk behavior in serodiscordant partnerships, to think about behavior change interventions specifically for that population. So in preparation for this conference, I did a review of behavioral factors for treatment uptake, linkage, and retention, and including TasP. Obviously, all of these things are relevant to TasP. And these are common factors across studies in sub-Saharan Africa as well as in the US and globally. So as we talked a lot about, stigma is a very big factor, a very big barrier to overcome. For example, going on treatment early and then might possibly reveal to others that one is positive, and so people don't want to go on treatment because of this anticipated stigma. There's also social support, which can be a barrier facilitator. So, for example, social norms around treatment and treatment acceptability would really help people start to engage and use TasP. But social norms against TasP, social norms that are discouraging, that are more stigmatizing, are going to be less. People are going to be less relevant and use TasP. So there's also social support in terms of adherence, and just having one person in one's life who's disclosed to, who one can rely on for instrumental support, get to the clinic, get medications, is very important in uptake of treatment and adherence. We also see a lot in the research literature, especially qualitative research, on cultural and religious attitudes, traditional medicine, and really traditional medicine and acceptance of traditional medicine in favor of these biomedical technologies and mistrust of biomedical technologies. Also see a lot of misconceptions around HIV that have to be overcome. And every community is different, and every community has different misconceptions and myths surrounding HIV and surrounding the treatments. That's why qualitative formative research is so important, to identify what those barriers are specifically and to create messages specifically for a community. It's also been talked today about perceived susceptibility and also perceived susceptibility in terms of feeling healthy. So why go on TasP? So I don't feel susceptible. I don't feel like I'm going to get sick. And now is not the right time. So people feeling healthy is a big barrier to TasP. And fatalism in certain communities has been a barrier as well. One of my studies is a fisher folk in Uganda, and fatalism is a big issue when it comes to HIV and getting treatment, because people feel like they could drown any day on the lake, and there's very high incidence of that. And so HIV seems so far in the future. Why go on HIV now, expose oneself to stigma and possible other complications from the medications? There's also relatedly side effect concerns, which are very high when people are thinking about going on TasP and really thinking, do I want to start treatment early? I feel fine, but there are side effects. And one thing also that's been mentioned today is gender violence, especially for women. So women who are in relationships and may not be able to disclose if they're in an abusive relationship that they have HIV, and feel like going on TasP would make them have to disclose that earlier or hide their medications. And another very big issue is mental health and depression, and across diseases, across conditions around the world, is one of the biggest predictors of non-adherence to treatment and non-retention and care, and same with substance use, alcohol and drug use. And finally, self-efficacy to take the medications is also a very important behavioral issue, and the confidence in one's ability to stick to the medication schedule and for life. So it's a very big concern where people say, I can't do that, so I don't want to start on treatment right away. And I wanted to also talk about, make sure we talk about the tangible and structural barriers that these behavioral issues fall into the context of. I mean, these are very important issues that come up in study after study, and I'm sure you've all known about these. And one of the biggest one is distance to clinic, distance to healthcare facility, or testing facility. That's a huge barrier to care, as well as transport and how one gets to the clinic, whether it's far, and related costs of transport. And another issue is mobility. For example, I mentioned the fisherfolk communities in Uganda, and that's one of the biggest barriers to linkage and retention and care. So just not being in the same place and not having one home is a very big barrier that we have to figure out, and that's been talked about today, that for example, men are at home, they may not live there during the week. So figuring out how do we get around these issues and create a system of care that can handle this mobility issue. I mentioned cost of transport, but obviously cost of treatment and testing as well, but in a lot of places that's not an issue. There's also employment as a barrier, having to take time off of work, and food insecurity and other competing needs that have been shown to be major barriers that we need to take into account. So Dr. McKema discussed the Machuti project earlier, and I was involved in one of the sub-studies of that project that was a qualitative sub-study that was led by Rebecca Plank and Shaheen Lockman, and several other people in the room are on this author list. And it was a qualitative study that used 12 semi-structured interviews and 2 focus groups to identify barriers and facilitators to uptake of TasP. And so it was among people who were eligible for TasP. And so in terms of the qualitative research, we saw several key themes in terms of barriers. And one is the big one we've all been talking about, the fear of stigma and not wanting to disclose one's status early, so not wanting to go on TasP. Also the fear of side effects. Also the belief, and the knowledge that, once I go on treatment, this is for life and I can't stop it, so I want to wait to start it. There was also the belief that, you can't take the medications with alcohol or traditional medicine, so people thought that and said, so I don't want to go on it yet, I want to wait as long as possible. And finally, people talked about a fear of disapproval, so this feeds into the social norms I talk about, and thinking that people in their community maybe didn't accept TasP and they didn't want to, and they weren't really sure about their church or traditional healers would approve of this, so they didn't accept TasP as well. But we did see some facilitators of TasP, or perceived facilitators. One we saw in some of the interviews was a perception of HIV as a disease like any other. So you'll see a quote that I'll show in a moment where somebody said, it's sort of like diabetes or anything else. I just need to take my treatment for it. So kind of normalizing the disease. And others said, I know that this will improve my health, so I should do it. Another one that's really a cue to action, or what we call a cue to action, is knowing someone who's non-adherent who died, or knowing someone who's just on antiretroviral treatment. So just knowing that, seeing that firsthand, that somebody really got better or somebody didn't because they didn't adhere, really was a cue to action to say, I better get on treatment too. And finally, the flip side is some people who thought that there was support in their community, that their family would support them in taking the medications, that their church was in favor of them doing this, were more likely to take it. So I just wanted to read 2 quotes that illustrated the stigma that we saw in some of the interviews. The first one is from a woman who was 51. There was one at our work, and it was known that she had this disease. Then I saw people scorned her. The others no longer use the toilet that she used. They changed toilets and told her to go to that one. It is still like that. And then another woman said, in my own family, I see it with my sister. It entered, then we were separated in the home. Hey, this person has a disease. Then you find you're given insults. It means we made a mistake, and it was better that some did not know what had happened. So those are 2 quotes that we saw that stigma really was there. But we also saw facilitators of taking TasP. You see that a person will not now be sick day after day, and they work. They were a patient who was sleeping in blankets. So showing that there's hope if you take treatment, it's a good thing. And the second one, oh, the virus these days, I see it as a disease like everything else. It's the same as just being sick with diabetes. It's no longer feared today. And obviously this is in contrast to some of the stigma quotes, but people did have varying ideas and varying barriers to whether they would take it or not. So just wanted to talk a little bit about what interventions might work for linkage, retention, and adherence, and what's been done in sub-Saharan Africa to really tackle behavioral issues. And so I won't go into these in depth, but I just wanted to mention them as things that might be add-on studies to things that are already being done to try to promote use of TasP, because these haven't been tested with TasP specifically. So for example, text messages have been shown to be successful in randomized controlled trials, but the important thing about text messages and reminders, for example, to go to the clinic, take medication, is that they have to be two-way. They can't be just a message saying take your meds or go to the clinic. It has to be an interaction, something that people can text back, and if they text back they're not doing well, then maybe some in-person or on the phone contact can happen after that. So it has to be followed up if there is an issue, else it doesn't work. It can't be a one-way test. It needs to be a two-way interaction. Also, lay and community health workers have shown great promise. We've talked today about home visits for testing and also counseling on adherence barriers that have been shown to be successful also in the US. They're doing well. They only have to go to the clinic once every 6 months. And one person in the group is tasked with going and getting the medications monthly for the whole group. So it really reduces the burden on the healthcare system and on the patient. And then another disappointing result we've seen is of adherence partners. And we haven't seen many good, significant results for using adherence partners and treatment buddies who help people adhere and remind them. In randomized controlled trials, these haven't been shown to be very successful. But I think the jury's still out. And I think they can be successful, but we need to figure out what kind of treatment partner is most successful. What kind of buddy should people choose to make sure that they stay in treatment? And the other two I wanted to mention, just point-of-care CD4 and healthcare system tracking. And these two things are still ongoing, and we're still waiting for results on these. No, I'm out of time. All right, I just have, okay, one more minute. So I also wanted to mention there have been interventions around stigma. That's such a big issue that we've been talking about today. And unfortunately, most of the results have been pretty disappointing. But there are a few randomized controlled trials. And most haven't examined long-term effects on stigma or behavioral consequences. For example, does it really reduce stigma in the community? Are people really discriminating less or just saying that they would, hypothetically? So we haven't really had good measures either for outcomes. And as I said, few interventions have been effective. And I think one of the big messages from this is that originally people thought if we introduce biomedical interventions, if we introduce HIV testing, that's enough because that'll change norms in a community. People will then be less stigmatizing because HIV will be more accepted and out there and talked about. But the few studies that have looked at HIV testing alone, for example, and not done any specific intervention around stigma itself, have not shown significant results on reducing stigma. But the couple effective interventions we've seen have actually mobilized popular opinion leaders in communities to go out and talk with people in their communities about HIV. Not necessarily talk about stigma, but just get the informal conversations about HIV going and destigmatize in general the norms talking about HIV. Those have actually been shown to reduce stigma. But no one yet has looked at the direct link between reducing stigma and improving HIV-related behaviors like TasP uptake. So there's really room to go in this field. So just, this is my concluding slide. Just want to say, well, so stigma and lack of social support are very common barriers across HIV prevention and treatment behaviors, including TasP, and really need to be attended to in any intervention. And effective interventions really are needed to address both stigma and retention and care, and both may impact the effects of TasP. But thanks.